first speaker, Dr. Nishi Satish, and she'll be presenting her talk on mitochondrial diseases of the eye, a plethora of findings. Over to you, Dr. Nishi.
Thank you so much, ma'am. A very good evening to everyone present here today. Like ma'am said, I'll be talking about the mitochondrial diseases of the eye. I have nothing to disclose. So mitochondrial DNA, we know it's circular double-stranded DNA, which is transmitted maternally. And here we've seen 10 patients who are diagnosed with mitochondrial disorders genetically, and we've tried to categorize them into their ocular and systemic findings. So the first group of presentations we saw were of optic atrophy, we saw retinitis pigmentosa, and external ophthalmoplegia and ptosis. So the first group again of patients with optic atrophy, we had these young teenage boys with bilateral painless progressive and sequential loss of vision. They had very strong maternal family history, and both of them had bilateral temporal pallor present, and on the visual evoked potential, we saw that there was a decreased amplitude as well as an increased latency. We called their younger asymptomatic brother over for examination as well. And although he was asymptomatic, we found optic disc changes in him as well, along with VEP and visual field analysis changes. We did a genetic panel testing for all of them and found that there was indeed a mutation in the G11778A. This was suggestive of Leber's. We sent these patients to neurology, and we found that they, although it appeared as isolated optic atrophy, they had peripheral neuropathy as well. We sent a patient to neurology. They sent a patient back with ataxia, tremors, a waddling gait, and she had difficulty in night vision since the last 2 months. When we examined her fundus, we found that there were some mild pigmentary disturbances present. We did an ERG for her and found that there were decreased scotopic and photopic responses. We combined all these findings together and thought, okay, this might be a patient of NARP. When we probed her further, we found that her younger maternal cousin also had similar features present. And when we did a genetic counseling for, analysis for them, we found that there was a defective ATP6 gene. Our next group of patients were of these ophthalmoplegia group, where this young girl with progressive ophthalmoplegia came to us. On fundus examination, we found that she did have pigmentary disturbances as well. When we sent her for a cardiac evaluation, we found that there was a first-degree heart block. Again, combining all these, we found that, okay, this might be a patient of Kearns-Sayre syndrome. And the next group of 4 or 5 patients that we had in our clinic were older gentlemen and older ladies who had chronic progressive external ophthalmoplegia. Some of them had cardiac conduction defects, some of them had sensory neural hearing loss. And the point here being that although the genotypic variations are so many, the phenotypic presentations of these cases are somewhat similar. They come with ophthalmoplegia, retinopathy, optic neuritis, and similar systemic presentations. One diagnostic tool which helped us a lot, especially in our ophthalmoplegia patients, was the muscle biopsy in the Gomori trichome stain, showing ragged red fibers. And new upcoming technology is coming up to recognize these fibers more easily. The treatment is common for all with an integrated approach, and the upcoming treatment in this is the gene therapy, especially for Leber's hereditary optic neuropathy. So patients with multi-system involvement, especially a younger age group with high energy utilizing organs, should prompt a suspicion for mitochondrial disorders. Family history is of utmost importance, and genetic counseling, especially regarding the maternal transmission, is very important in these patients. These are my references. Thank you.
So, with regard to Leber's, what percentage of patients do you think can have Leber's yet not show up on the primary mutations that we normally test?
So we test mainly for the 3 mutations on ND1, ND4, and ND6, and almost 70% of them do show up on that panel, sir.
Yeah, so I think earlier the thought was used to say about 90%
Yes,
have,
sir.
but now it's come down.
Yes,
There's
sir.
a lot of secondary mutations that
Yes,
come
sir.
into play. And that's where if you do a good genetic counseling or you do a good pedigree, you can actually make out.
Yes, sir.
And it's not necessarily that Leber's would have a full penetrance in terms of.
Yes, sir. Exactly. Yes.
Yeah.
So how would you prognosticate based upon the genetic findings that you have? So you talked about genetic counseling. So for individual cases, the counseling would be different.
Yes, ma'am.
So what would be the likelihood for each of the cases that you described?
So in mitochondrial disorders, we have to note something about the penetrance of the disease, where we don't know how many percentage of these mitochondria which are affected will be transmitted to the offspring. This is very important in these patients. And regarding their familial history, especially the maternal background, we have to take all of those things into consideration while giving them that counseling.
Fair enough. All right. Thank you.
Thank you so much.